Uh, can you hear me?
Good afternoon, sir. Yes, sir.
Okay. Today we'll talk about this inflammatory bowel disease, and um, mm, I think we have got two classes on this, but I think I'll be able to finish it in one class. Um, these inflammatory bowel diseases are in short also called IBD, but you should not be using this IBD uh, mm, as a short form, because IBD even can be considered as for irritable bowel disease or bowel syndrome also. So in inflammatory bowel disease, we have got mainly two diseases. One is ulcerative colitis and another one is Crohn's disease. So I will talk about two diseases, and from the exam point of view also, these two diseases are quite important, because we see that there are lots of questions coming from these two diseases. So for the when it started, this is actually an idiopathic and chronic inflammatory disease of the bowel, especially of large bowels. But in Crohn's disease, the involvement of bowel can be from mouth to anus. So there's no, it doesn't only cover large bowels, but for ulcerative colitis, it's on for the colons only that are involved. So for the definition, it's an idiopathic chronic inflammatory bowel disease, and we have two entities. These are ulcerative colitis and Crohn's disease. Incidences of these diseases varies with regions, and these are quite common in Western people, and we don't have exact data from our country, but it's when we look at in the practice, it's common also here. The age of onset is bimodal. One is between 15 to 13 and another is 60 to 80. And male-female ratio is around 1 to 1.8. So females are more commonly involved than the males. So the initiating factors, I wouldn't say initiating factor, but risk factors, or that may predispose this disease, especially of Crohn's disease, are smoking, and oral contraceptive pills can also predispose to Crohn's disease. This inflammatory bowel disease runs in families also, and they are more will have one common locus called HLA-DR 103. So if the family has this locus, then the inflammatory bowel disease can run in families also. For the etiology and pathogenesis, we don't know actually. There are many theories, and whenever you have got many theories, that means we don't know at all. So why this occurs and what is the pathogenesis behind this disease, actually we definitely do not know. And these usually are seen in genetically predisposed individuals, and infectious agents are sometimes taken as a causative factor for this inflammatory bowel disease. And it also depends upon the host factors also, like what is the vascular supply of bowel, or what are the neuronal activities, and what the intestinal barrier function is good or not, or whether it is protective or not. So it may depend upon these factors also. But even though we say that this may be because of infections, but not a single infectious agent has been identified, and that's why we don't know why this occurs. If you look at the differences of ulcerative colitis and Crohn's disease, then in US incidences, ulcerative colitis is more common than Crohn's disease. Age of onset is more or less equal, but for ethnicity, Jewish and Caucasians have got more incidences of ulcerative colitis and Crohn's disease than those who have come from Asian countries. So, male-female ratio is around Crohn's disease, it's more in the females. Smoking causes the disease in Crohn's disease, but it may prevent ulcerative colitis, but we don't have a very good data on this, so you should not be starting smoking to prevent ulcerative colitis. Oral contraceptives are usually associated with Crohn's disease, and it's more like a person who is taking oral contraceptives would have 2 times more chances of having Crohn's disease than those who haven't taken oral contraceptive pills. In Japanese studies, they have found that appendectomy is protective for ulcerative colitis, but it's not for Crohn's disease. And these are more common in monozygotics. Crohn's disease are more common. In dizygotics also, Crohn's disease is more common. So we see that Crohn's disease may have more familial predisposition than the ulcerative colitis. Whenever we will now talk about in a different one by one, like for ulcerative colitis, it usually is a mucosal disease, and usually it does not penetrate beyond this, but involves the rectum and part of the colon. So ulcerative colitis are usually generally a disease of rectum and only a part of colon. Proximal spread occurs in continuity without areas of uninvolved mucosa. So it's continuous, and continuous mucosa is involved continuously. There is no skip lesions. We call that one as a skip lesion. If there is a uninvolved mucosa in between, then we call that part as a skip lesions, which is common in Crohn's disease actually. So in ulcerative colitis, you will have a continuous involvement of mucosa. If you look at the mucosa, then these are erythematous, granular. Later on, they ulcerate and hemorrhagic also. There may be pseudopolyps, and because of the complications, patient may have developed toxic colitis and megacolon, where megacolon means it's like a, if you look at the, I have got one X-ray for that, the colon will be very big, and it seems like a tire also. And sometimes it may be difficult to differentiate between obstruction or megacolon. If you look at the mucosa under the microscope, then there will be a distortion of crypt architecture, and there will be infiltrations of inflammatory cells like polymorphs will be seen. And in the clinical feature, patient may complain of rectal symptoms, especially like bleeding, tenesmus, or passing the mucus with the stool. Some patient may have diarrhea, crampy abdominal pain, or may even pass fresh bloods also, clots as well. So for the complications, patient may have hemorrhage, patient may develop perforation, toxic megacolon, and obstruction. So this is the colon, and with what we see under the microscope. So there will be crypt distortion in that. And if you look at it, the involvement of mucosa is continuous without any skip lesions. And this is a toxic megacolon. So it sometimes look like a intestinal obstruction as well. In the Crohn's disease, it can affect any part Okay, and there are skip areas also. So this is not a continuous lesion as that of ulcerative colitis, and there will be normal mucosa in between the involved mucosa. And there may be presence of fistula, feces, abscess, or there may be stenosis also of the stenosis of bowel. And this is transmural, and moreover, Crohn's disease is mucosal, but this is transmural. There may be a superficial ulcers, or which may be cobblestone appearance, and in microscope, you'll see ulcerations, crypt, abscess, and granuloma. In Crohn's disease, this is very typical in Crohn's disease. You don't get granuloma in ulcerative colitis, but in Crohn's disease, you can have granuloma. There may be, like in clinical feature, may depend upon what kind of lesion patient has got. Like if the patient has got fibrous and it is stenotic, then patient may present with obstructive features. If it is penetrating, then there may be fistulous pattern, and patient may have similar symptom of like that of ulcerative colitis, like bleeding, mucosa in stool, may have pain abdomen also. If rectum is involved, then they may have also this feeling of tenesmus. And because patient may have lesions anywhere in the bowel, so patient may have ileocolitis or jejunoitis, colitis or perianal disease. Even gastroduodenal diseases are also mentioned because of. Hello. Sorry.
You start with the red one. Red one will be very easy to start. And you don't keep the ankle like this. Try to keep it straight. Okay.
Hello.
If you start with the other way, so you understand more easily.
I didn't get it. What are you talking about?
Hello. Ligament will be torn. Okay. So there are certain muscles, they work along with the ligaments. So it's like back of tissue. So we are going to use only that tissue to stabilize the ankle. Okay. Just we'll try with the right one first. Right leg, keep it straight. Okay. So basically you are going to do this movement. Actually, this movement will cause more damage for your ankle. Never do that movement, but you are going to do the opposite movement. Okay. So
I
along
think
with
we're
that,
having some problem with there are two.
holding
What is this?
down leg. Okay. Yeah.
So in complications, you can have fistula, perforation, or abscess. Abscess within the layers of the bowel, and
just turn.
these are for diagnosis. You'll have elevated ESR, C-reactive protein will be high. Patient will have hypoalbuminemia because of malnutrition, anemia, and may have leukocytosis where the patient has toxic megacolon. You can go for endoscopic examination, either upper GI endoscopy or maybe the colonoscopy, and you'll directly can view the lesion and take a biopsy from that, and then diagnose it. So this is quite important test for us to diagnose inflammatory bowel disease, and also to see whether it's a Crohn's disease or it's a
start clinical also.
Second is introduction, like orthopedic.
In radiography, we can do a we can give a barium meal and look at the structure, that the picture that I just showed you a few slides back is a example of radiography. There are few serological markers, and these may be positive in some cases of Crohn's disease, and that also. So in Crohn's disease, you can see that this is a stenotic lesion, okay, and the patient, this one is unaffected. So you'll have a skip area like this, and this is a granuloma that is present in the biopsy. So you'll have a particular involvement somewhere is there, somewhere it's any lesion. So you'll find it like that. This is also, there's an abscess here. And this is a very favorite question for exam, to differentiate ulcerative colitis and Crohn's disease. And it's quite sometimes obvious that you can differentiate ulcerative colitis from Crohn's disease. Like usually the ulcerative colitis would have symptoms of lower bowel, rectum, and so the patient would have blood in the stool, mucus in stool, which is not very frequent with Crohn's disease. But systemic symptoms are more common with Crohn's disease, and there are some extra intestinal manifestations also, which are more common with Crohn's disease. There will be more of fistula in the Crohn's disease. Other involvements like small intestine or colonic obstruction are more frequent with Crohn's disease, because there are two, as I said, there are mainly two kinds of lesions in Crohn's disease. One is obstructive, and so there will be small intestinal obstruction, and you'll have a good response with antibiotics in Crohn's disease. Recurrence is more common with Crohn's disease, and ANCA would be positive with ulcerative colitis, and ASCA with the Crohn's disease. You'll see that there will be sparing of the rectal sparing in the Crohn's disease. Continuous disease is more common with ulcerative colitis, and in Crohn's disease you'll have skip areas. Cobblestoning is common with Crohn's disease, and granuloma, which is very, very, if you find, you'd be lucky, and you'll be able to differentiate whether it's ulcerative or Crohn's, because in ulcerative colitis you will not get granuloma, but in Crohn's disease you may get it. So one of the importance of Crohn's disease for us is that this usually affects the small bowel, terminal ileum area, and this is also a place where you'll get tuberculosis of intestine. So in our part of the world where tuberculosis is very common, you'll have to first rule out tuberculosis before you diagnose inflammatory bowel disease. So and there are few indications for surgeries. If they have a toxic megacolon or fulminant disease, if you have a obstruction, ulcerative colitis, you go for surgery. In Crohn's, if you have a stricture, massive hemorrhage, abscesses, or some obstruction, or may have there may be colonic dysplasia or cancer, which would indicate that a patient should go under surgery. There are few extra intestinal manifestations, and as I already said, that these are more common with Crohn's disease. So dermatological, like erythema nodosum, pyoderma gangrenosum, In rheumatology, ankylosing spondylitis, in ocular, uveitis, scleritis or conjunctivitis, and in hepatobiliary, primary sclerosing cholangitis. In there are other like urological, thromboembolic, cardiopulmonary, and as these are chronic diseases, patient may convert into amyloidosis as well. So there are many extra intestinal manifestations, and this is more common with Crohn's disease rather than the ulcerative.
Slightly attached. Maybe you put that slab, it will
The treatment it's like
nothing is under connection. Then automatically
it can be given locally or
Excuse me, sir.
it can be given systemically.
Excuse me, sir.
No use. It's completely destroyed.
Okay.
There's no
And
chance it will join.
Sir,
Not
hello.
recently.
sir, just a minute. हाम्रो मध्ये कसैको mic on भयो? एकछिन गरिहाल्छु. Sarabjit, can you turn off your mic?
You don't bother, but you cannot suddenly jump or do anything. Suddenly it will twist again.
Sarabjit, can you turn off your mic?
The joint will get damaged. The cartilage will get damaged, and it cannot be reversed when the cartilage is more damaged. Otherwise, you also be safe with the brace. You should not do any risk activity, no sports activity, no running, no twisting the ankle. Steps also you have to climb very slowly.